So what we're going to talk about today is hemostasis. Hemostasis is a really fast series of reactions for the stoppage of bleeding. It requires clotting factors and other chemical substances that are released by platelets and even injured tissues. Now it's important to first note the 3 steps involved in hemostasis, or the stoppage of bleeding. That is step 1, the vascular spasm. That is step 2, platelet plug formation. And step 3, coagulation, or what's actually blood clotting. So let's start with step 1. This is when the vessel responds to injury with vasoconstriction. That vasoconstriction is what we're calling the vascular spasm. Remember, vascular refers to blood vessels. And vascular spasms are triggered by injury to the smooth muscle inside blood vessels or direct injury to vascular smooth muscle, the release of chemicals by the inside lining of those blood vessels and by platelets, or chemicals released by endothelial cells and platelets, and pain reflexes as a response to injury. Now, a vascular spasm, or this vasoconstriction, where the diameter of the blood vessel gets smaller quickly, is most effective in smaller blood vessels because that can significantly reduce blood flow until the other mechanisms or the other steps of hemostasis kick in. That spasm response is really valuable because a strongly constricted artery, especially small ones, can significantly reduce blood loss for 20 to 30 minutes. And so we really want those next steps, platelet plug formation and blood clotting, to occur without excess blood loss. That's the point of step 1, the vascular spasm. Step 2 is the platelet plug formation. And this when platelets are triggered to start to stick to the visible collagen fibers that are exposed when the vessel is damaged. Platelets don't normally stick to intact blood vessel walls because collagen is not exposed. It's the breaking of the blood vessel and the showing of collagen fibers to platelets that allows for the secretion of chemicals from platelets and for platelets to become initially sticky. Also, there's prostacyclins and nitric oxide, and those are secreted by endothelial cells, or the inside lining of blood vessels, to act as preventative platelet sticking regulators. So platelet plug formation doesn't just happen whenever we need it, unless we have the stimulus, which is broken collagen fibers from outside the blood vessel being visible inside the blood vessel. And we actually use von Willebrand factor to help stabilize these platelet collagen adhesions that begins the platelet plug formation cycle. This step is actually a positive feedback cycle. As more platelets stick, they release more chemicals, which cause more platelets to stick and release more chemicals, and so on and so on. Remember, a positive feedback cycle is an amplification event. And platelet plugs, which are what we're trying to get at the end of step 2, platelet plug formation, are going to be great for small vessel tears, but larger breaks in vessels are going to need that additional 3rd step. Now, when platelets are activated, the chemicals they release are going to be ADP, which is a breakdown product of ATP and causes more platelets to stick and release their contents. It also includes things like serotonin and thromboxane A2. These enhance that step 1, or vascular spasm, but also help with platelet aggregation, or forming that platelet plug. And platelets actually are able to release these chemicals because once activated, they swell, they become spiky and sticky, and that's the trigger initially for them to release their chemical messengers. But remember, bigger blood vessels may also need coagulation or blood clotting. They might need reinforcement to that platelet plug. And that reinforcement comes in the form of fibrin threads. Fibrin threads will strengthen blood clots, and they'll become very effective in sealing the larger vessel breaks. This really is going to be where we see blood transformed from a liquid to a gel. This actually is going to include a series of reactions that use procoagulants, or clotting factors, that are mainly plasma proteins. They're numbered generally from 1 to 13. They're in the order of discovery, and many of them need vitamin K to be synthesized. And coagulation is going to occur in 3 phases itself. So before we continue on and look at the different phases of coagulation, let's review. So step 1 for hemostasis was a vascular spasm, where we get vasoconstriction to stop blood flow as much as possible. Then step 2 was platelet plug formation, which is great for small vessels, and you might not even need step 3, which is coagulation. Platelet plug formation was a positive feedback cycle, and the stimulus was visible collagen fibers at the break. causing platelets to adhere. And coagulation is when we need to strengthen that platelet plug, which is especially common in larger blood vessels, where we'll see a fibrin mesh form, and it'll be a mixture of things like red blood cells and platelets, and it forms a really strong clot. But back to coagulation. So there's phase 1 for coagulation, and that's essentially the two pathways that lead us to prothrombin activator. Prothrombin activator is something we need to go to step 2 for coagulation. Now, in order to get prothrombin activator, you can either initiate the beginning of this step intrinsically or extrinsically. So maybe this step was triggered by tissue damaging events, or a series of procoagulants were activated. But regardless if you use the intrinsic or extrinsic pathway, each pathway is going to produce at the end something called factor X. And factor X is what's going to complex with other chemicals like calcium and platelet factor 3, factor 5 to give us prothrombin activator. So the intrinsic pathway is called intrinsic because the clotting factors would be present within the blood, whereas the extrinsic pathway was called extrinsic because the factors needed for clotting are located outside the blood. But regardless if we're using the intrinsic or extrinsic pathway, at the very end, so look at the bottom of this image, things like PF3 and calcium are all going to coagulate together and give us factor X. And factor X will help us form prothrombin activator. And why do we need prothrombin activator? Well, that's because phase 2 of coagulation is using prothrombin activator to transform prothrombin into thrombin. And then phase 3 is to use thrombin to convert fibrinogen, which is soluble, it's kind of dissolved in the blood, to insoluble or more solid fibrin. Because we need fibrin, we need those strands. It's the big thing about coagulation because they're going to form a more structural basis for a blood clot. They're going to mix with red blood cells and proteins and with that platelet plug. So we're going to essentially create a gel-like trap catching all formed elements. We're going to use things like thrombin to be a stabilizing factor, and we'll cross-link all of these fibers, which is what fibrin is, to strengthen and stabilize the clot. And it'll stay there essentially until growth factors are produced. And then finally it'll be broken down later with anticoagulants, or factors that normally would dominate in the blood and would inhibit coagulation. Those will become more abundant after we've healed the break. All right, so let's review. After we get thrombin, it turns fibrinogen into fibrin, and we get a cross-linked mesh. So here are those steps. So again, after we got thrombin, it turned fibrinogen into fibrin, and then we got the cross-linked mesh. The whole step was whether we use the intrinsic or extrinsic pathway, they result in factor X, which complexes with calcium and platelet factor 3 to give us prothrombin activator. Prothrombin activator turns prothrombin into thrombin, and when we have thrombin, it turns soluble fibrinogen into fibrin. Fibrin is more solid, it's insoluble in blood plasma, and it complexes with the platelet plug to give us a cross-linked fibrin mesh, or a true blood clot. And here's what that blood clot might look like. So you can see it's catching tons of things like red blood cells, and it would also trap other platelets and continue to trap kind of what comes by. We even stabilize the clot further by doing clot retraction, which is actin and myosin contraction, which is found in platelets, that occurs within 30 to 60 minutes of clot formation. And that contraction is going to pull in the fibrin strands, squeezing serum or fluid from the clot, and serum is just plasma minus the clotting proteins. And that's going to help draw the two ends of the broken blood vessel together. And then over time, we're going to start to see healing thanks to different growth factors like platelet-derived growth factor and vascular endothelial growth factor. Once healing has occurred, we have to get rid of the clot. We don't want it to stay. Fibrinolysis is the process where the clots are removed after the repair is completed. Usually it begins within 2 days and continues for several days until the entire blood clot is dissolved. Now, plasminogen is a plasma protein that's trapped in a clot. And when it gets converted from plasminogen, which is inactive, to plasmin, which is active, then it can help break down the clot. What converts plasminogen to plasmin is tissue plasminogen activator, or TPA. So that's going to play a role in the conversion process to start up fibrinolysis. Now keep in mind there's factors that limit normal clot growth. Usually there's a very swift removal because of continued blood flow once we have brought those two broken edges of a blood vessel back together, by dilution, because blood flow is going to continue. There's also inhibition of activated clotting factors, so we turn off the procoagulants and start to activate anticoagulants, and there's going to be a limited amount of thrombin that's available to turn fibrin threads active. And that's going to prevent the clot from getting too big or escaping into the bloodstream. There's also antithrombin 3, which inactivates any unbound thrombin that does escape into the bloodstream. And then heparin and basophil and mast cells inhibit thrombin by enhancing that antithrombin 3. And there's also factors that would prevent undesirable clotting when you don't have a broken blood vessel. And that is the fact that smooth endothelium of blood vessels usually prevents platelets from clinging. But when you have a broken blood vessel, there's some friction there, and it's a little bit easier for platelets to stick. But usually we also have endothelial cells that secrete antithrombic substances like nitric oxide and prostacyclin. And there's even other chemicals like vitamin E quinone that can react with oxygen to be a potent anticoagulant. So as long as we don't have that initial stimulus of friction and kind of tears in blood vessels and collagen being visible to platelets, then there's other factors that will prevent undesirable clotting when those stimuli are not present. Now, of course, there can be some disorders of hemostasis, like thromboembolic disorders, which result in undesirable clot formation, and bleeding disorders or abnormalities to prevent normal clot formation. There's even DIC, or disseminated intravascular coagulation, which involves both types of disorders. So let's first look at the thromboembolic conditions. So we're going to look at thrombi and emboli. Make sure you know the definitions of a thrombus and an embolus. A thrombus is a clot that develops and persists in an unbroken blood vessel. So that can block circulation, it can lead to tissue death, but it is going to be a clot still attached to the blood vessel. Now, an embolus is a thrombus that is broken away from the blood vessel and is now freely floating in the bloodstream. So an embolism is when that freely floating blood clot gets to a really small blood vessel and completely obstructs it. And that can lead to a cerebral or pulmonary embolism, more likely than not. And risk factors for the development of a thrombus that might turn into an embolus that could cause an embolism, or atherosclerosis, inflammation. Those things produce either interactions or disruptions to blood flow, or friction and kind of bumpy inside layers of blood vessels that allow for platelet sticking, or even slowly flowing blood or blood stasis from immobility. Those can lead to thromboembolic conditions. Now, one way to treat these would be anticoagulant drugs used to prevent undesirable clotting, like aspirin, heparin, and warfarin. There's also bleeding disorders, and those include things like thrombocytopenia, which is when you don't have enough platelets circulating in your blood, and that can lead to petechiae, which are small hemorrhages, and they're usually spontaneous but quite small. It's usually due to the suppression or destruction of the red bone marrow. Maybe there's a cancer malignancy, maybe radiation, or even drugs. And a platelet count less than 50,000 per microliter is the diagnostic criteria for thrombocytopenia. And of course, they'd also be looking for petechiae. And the treatment would be a transfusion of concentrated platelets. So here are petechiae in the extremities. Each one of these little dots is going to be hemorrhaging into tissue from the blood. And then we have bleeding disorders that might be caused by impaired liver function, because you need procoagulants because they are pro-coagulation or clotting. And if you have impaired liver function, you might have a vitamin K deficiency. We see that also with hepatitis and cirrhosis. So if you can't produce or absorb what you need to make the procoagulants, they're not there, and it can lead to a bleeding disorder because they're not there to help with clotting. And instead we get an abundance of blood that's not clotting when it should. There's other bleeding disorders like hemophilia. This is genetic. It's going to include several different versions of the disorder. The most common type is hemophilia A. It's about 77% of all cases. And symptoms are going to include prolonged bleeding, especially into joint cavities. And the treatments now are injections of genetically engineered factors. And that should eliminate the need for plasma transfusion and the risk of contracting hepatitis or HIV. And then last but not least, we have disseminated intravascular coagulation, or DIC. This involves initial widespread clotting and then severe bleeding. Because of the widespread clotting that occurs in intact blood vessels, you might get blocked blood flow, but it also ties up all of the clotting factors, which means elsewhere where blood flow isn't blocked, you might see severe bleeding because residual blood isn't able to clot because those clotting factors are being depleted. Now this can occur when you have septicemia or an incompatible blood transfusion, or even as a complication in pregnancy. So just keep in mind that you have clotting disorders and bleeding disorders, but also disseminated intravascular coagulation, which includes both. All right, so that's it for hemostasis. So we're also going to move into blood transfusions and blood typing in the next video, so make sure to watch that as well.